One of the things that's been done really well, and Steve's a pretty modest guy, the bloke this morning, Steve Robertson. So out of 2007, he comes up with this book, and it was really important. And he came up with this notion about control, release, don't care, should care. And he put hegemonic masculinity in the middle. I'll forgive him that, because I reckon it should be plural, Steve. But it was really, really useful for these 4 quadrants, because what Steve did, along with a few others, was to say, OK, well, hang on, hegemonic masculinity is not all bad. There's opportunities here for strength-based models of masculinity about how we do health. And so that was a very, very important moment, that Steve came up with that. We still need to keep pushing these theories forward and keep working with it to anchor some of these behaviours and practices, and to also contextualise what it might look like within different socioeconomic status and different parts of the world, and also different cultures. I was so sorry Michael Addis couldn't be here today. Addis and Malik, came up with the Conformity to Masculine Norms Index. Really important work again. 94-item piece that you would fill out and get a sense of, to which masculine scripts men align to within particular illnesses. I think it's interesting, and I'll come back to this survey questionnaire. Oftentimes the qualitative-quantitative piece, epistemologically, ontologically, it gets hard to reconcile and we battle with it, but I do think it's an important conversation to have, and I'll broach it a little bit in methods. The piece that we're working on at the moment is called gender relations. I think in the midst of the whole thing, I've had a decade of working with men. I talk to men about men. And then it sort of dawned on us that, Connell was saying, well, it's relative, right? It's a relative notion. It's about co-constructions of gender. It's about how you communicate. It's how you work with others. And so we took the work of Howson out of 2006 in a book called Challenging Hegemonic Masculinity, and we've started to do gender relations. Now, what I've put forward here is, on one side, you've got a stratification of masculinities, complicit masculinities, marginalised and subordinate, and on the other side of the equation, emphasise femininity, ambivalent femininities, and protest femininities. So, this could be the masculinities on both sides. This could be femininities on both sides. This could be about heterosexual couples. This could be about sons and daughters. This could be about daughters and sons, dads and daughters, the whole way. And what we're putting forward is this notion that it's co-constructed. So we're trying to do what we would refer to as gender relations. Important to note that Howson's work, it looked at the judicial system in Australia, and so it wasn't really built for health, but we're adapting it. I won't go into this because I'm presenting it tomorrow in the afternoon, in an afternoon session. But we've looked at couples where the man self-identifies or has a formal diagnosis of depression, and it's in straight couples, and so we interviewed the women and the men separately and then put their narratives together to come up with a notion about how they do gender in the context of a man having depression. Given that most depression, management plays out at home, given the healthcare system, we thought it was particularly useful to sort of get into some of that work. Ever so briefly, I'd say that what we were struck by was this notion of trading places, and that some of the gender roles that we typically assign, so women looking after the health of men, being the therapeutic advisors, were kind of flipped. And so we actually came up with the notion that really what people were doing in the vast majority of cases was something called tough love, where the woman would be appealing to the masculine strength about autonomy and self-management to help the man take control of his own depression and the management thereof. But of course, I'll have more time to talk about that tomorrow if people are interested. Methods, so the third part. I find it interesting when we review grants or when we write grants, and their mixed methods grants. I think we've got to start thinking about whether it's a parallel design or whether it's a sequential design. So are we answering the same questions with a qualitative, quantitative focus? Really important. Or is it a series? Are we doing a series here? Like, are we going to answer one question with the qualitative piece? Are we then going to answer a different question with the quantitative piece? And so I come back to Addison Malik's work about conformity masculine norms. I think that tool's got a little way to go, but I think we should be starting to think about how we might be able to use it with the qualitative work. I'm not a quantitative researcher, so I'm out of my depth with the survey questionnaire work. But I am struck by this notion of whether it's a predictable variable, mediating variable, or outcome variable. Like, what is it we're saying masculinity is? How do we position it? Because my major interest in that is well, okay, so if I know that going in answering the question, then I might have an idea about intervention. And intervention ultimately is what we want to do. The other thing, the masculinity piece in terms of collecting data, the Web 2.0, this notion that we might be able to collect data on the internet, this idea that men might go to the internet and we might be able to intervene in certain health areas with men, I think is fascinating. I think it's new. I don't think we're quite there yet, but I do think there's some really good emergent work. Rod Knight, who's presenting tomorrow, does some terrific work around sexually transmitted infections and young men, and this notion, putting forward this idea of interventions on the internet, and he's doing some great work. The other thing that tends to happen increasingly, the Institute of Gender and Health is asking researchers to design studies that address both gender and sex. Not easy. Again, epistemologically, ontologically, and even getting into a room with people who do bench science is quite difficult to sort of get that conversation. But increasingly it's what they're after at the Institute. I think for good reason. I think it gives you a thicker description of the problem. I think idyllically, and this might be an idealised kind of idea, but it pushes towards interventions quicker. And I think that's part of what the pressure that we might be under at the Institute of Gender and Health is as well. Finally, the model of masculinity in terms of the methods. I think it's, in terms of the qualitative work, I think we've been very, very good at describing problems. I think that's great. I think you need to describe the problems. They need to be thickly described in order for you to come up with the solutions. But at some level, we haven't inductively derived what masculine norms are or what hegemonic masculinity is, or we haven't quite got there. So there's still this kind of leap of logic that we all know what we're talking about, and then we'll start anchoring in these different contexts. And so in a world that's kind of globalised, and immigration accounts for 40% of our population in Vancouver at the moment, I'm struck by, even when the practices look the same potentially in how someone does health, it might actually come from a completely different place. So case in point would be some of the work we've done with South Asian men, where it's often based on a notion of kismet, or savour, doing a community service, and it looks quite different, but the practices around health look the same. So, your intervention points change. Methods versus programs versus KT. So this knowledge translation is very, very interesting at the moment. And one of the things we've done with dads who smoke, we took what has been situated as a women's health issue for the longest time, which is smoking in pregnancy, and we flipped it and we said, well, hang on, if we're really doing gender relations here, what about the guys? What kind of conversation could we get going with the guys to talk to them about their smoking? Because if you have a partner who smokes, you're 3 or 4 times more likely to smoke yourself, and your children are also more likely to smoke. So it's intricately connected. So to intervene with women seemed quite lopsided in the notion of pregnancy, because men too influence secondhand smoke, influence the partner smoking. So we had a program of research, and for 6 years we described the problems about men smoking in the context of fatherhood, where they were smoking. So the guys were smoking in cars because they could still be a direct caregiver to their child because they were smoking in a car that their child never travelled in. They'd smoke at work if they were in construction industry because there was still a smoking pit. So they could compartmentalise their smoking quite well. So we took their narratives and we developed an intervention or a booklet that's available online. And it's called The Right Time, The Right Reasons. Dads talk about reducing and quitting smoking. So rather than scripting them out on how to quit, we just really used their narratives to talk about the challenges that are associated with being a dad and smoking, and worked it in that way. We had a very clear plan from the outset that we did want to do interventions. We didn't know how to do interventions, so we described the problems for 6 years and eventually got to the interventions. And now, one of our challenges is to evaluate the intervention with some hard data, and we are really struggling with that at the moment. So I'd love to hear some feedback about how people might be doing that, because we feel like we've got good uptake. We've got, I think, 3 or 4 provinces have picked it up. They pay for their own printing of this document, and they're using it in the health authority. So we're flattered, but we don't know its impact in terms of how it might be helping, or in terms of sheer numbers. Finally, I'll finish off with a little piece around policy. So there is an interest at the moment in Canada to have a men's health policy. They're beginning a conversation. The Public Health Authority of Canada, the Institute of Gender and Health. I think it's really, really important that the policy has some teeth and has some traction. So I think we need to go back to this tripartite, the empirical, the methodological and the theoretical, and to better develop this knowledge base that we've got, this evidence base that we've got, in making the case that a policy should come. A policy without that kind of basis, I don't think is going to work, would be my guess. And it's great that John McDonald's here and delegates from Ireland as well who've got some experience around this, and again, keen to talk to them. But in Canada, I think we really do need to learn from the experiences of others in pushing forward this notion of a policy. I'd love to see some centres for men's health. I'd love to see some work coming out of melting pots like this meeting to push all of those agendas forward. Finally, we have a website. Please visit us. We're trying to make materials downloadable there for you, as many of our articles as we can possibly free up for people, and the men's smoking booklet is also there. Again, sincere thanks, Gillies, for the chance to be here, and just had a great day and really looking forward to the next couple of days, and thank you so much.